All right, welcome to the Society of Academic Emergency Medicine's Research Learning Series, or RLS. My name is Cole Lettingoff. I'm a medical student at Trinity School of Medicine, and I'm delighted to be moderating our session today on community-engaged research, what and how. Many among SAM's membership make incredible contributions to furthering research related to emergency medicine and associated disciplines. As we pursue advances in the field, it is critical that we not only ensure our efforts do not harm our patients, but that we recognize community members as our partners in setting the direction of EM and are critical to its success. A few brief housekeeping items. First, if you're watching live with us, please feel free to post any questions in the chat, and we should have some time for them at the end. You can also send those to me directly if you'd prefer. Our session is being recorded, and the recording will be available on the SAM website, as well as SAM's YouTube page. We will begin with some brief introductions, after which each of our speakers will provide a brief presentation. You're welcome to submit questions at any time, and respectful conversation in the chat is always welcome, but I'll hold off on posing questions to our speakers until all three presentations. All right, so without further ado, allow me to introduce our speakers. We have with us three leaders in the space of community-engaged research, each with a unique background and valuable perspective to do. First up, we have, got these out of order, didn't I? Excuse me. First up, we'll have David Yang. David is a Yale Emergency Scholar and EMS Fellow in the Yale Department of Emergency Medicine. He completed undergraduate studies in biomedical and electrical engineering at Washington University in St. Louis, medical school at LSU in New Orleans, and most recently in MHS at Yale, where he also completed his EM residency. Nationally, he has served on the Equity and Inclusion Committee with the Society of Academic Emergency Medicine, and at the local level, he works closely with the Sexual Assault Forensics Committee and as an interprofessional longitudinal clinical experience mentor. His current research focuses on addressing disparities of care in three domains: discrimination that healthcare workers face in the clinical setting, disparities in care for survivors of sexual assault, and pre-hospital disparities in care for behavioral emergencies, a subject that I may be picking David's brain on for another project soon. Following David will be John Soski, who is a person in long-term recovery from drug and alcohol addiction, and a researcher who uses ethnographic and community-engaged strategies to understand the ongoing systems crisis in substance use and mental health treatment. He is currently a research associate at the Lifespan Division on Addiction Medicine, where he's a member of the team opening Rhode Island's first bridge clinic, and a Systems of Care Fellow at the Center for Complexity at the Rhode Island School of Design. And last, but certainly not least, is Elizabeth Samuels, an emergency medicine physician, health services trains researcher, and associate professor of emergency medicine at UCLA. She completed her emergency medicine training at Brown, a health service research and health policy fellowship at the Yale National Clinical Scholars Program, and is board certified in both emergency medicine and addiction medicine. Her work focuses on social emergency medicine and health equity initiatives, specifically community health worker and peer recovery programs, harm reduction services, low barrier substance use disorder treatment, care for transgender and gender non-binary people, healthcare workforce diversity, and emergency department programs to address health-related social needs. We're excited to have all three of you with us here today. I'm going to hand it over to David to get us started.
Great. Thanks so much, Cole. So I've been tasked with basically communicating the what, not the how, of community-engaged research. So we'll talk about that for the next 5 to 10 minutes before I pass it on to John. So just in terms of what is community-engaged research, I like to think about it in this way. It's a process that incorporates input from not just the academic researchers, but importantly, the people who really this research outcome will impact, right? So I think the important things to emphasize here are it's not just a one-time thing. It's a process, it's iterative, and throughout the entire research design, from way before you even start the project towards way after you in at least that initial project, both the academic researcher and the community partner are equal partners. I think that's really important, and I'm sure others will emphasize this later, but the concept of what an equal partner is really difficult and challenging. And as most of us are academic researchers primarily, we should really think critically about how to ensure that we are all equal partners in this type of research. So just to expand a little bit more on why community engaged research is important, both from an academic researcher perspective and from a community organization perspective. For the researchers, I think it's really valuable because it allows you to improve not just the quality of your research in terms of accuracy of your measurements and how valid your study is, but it also allows you, when you're considering what research projects you want to do, to ensure that the type of research you endeavor to accomplish really focuses on something that can positively impact the community that you're interested in. And I think that's really important for all of us, because doing research for the sake of research is not what any of us are really interested in. It's really thinking about what can positively impact that community. And I think sometimes this is some discordance between a researcher and a community organization, is what is something that is meaningful for that community. From a community organization side, really, it allows them to engage with these researchers. And these researchers are people who have resources and expertise that the community organization might not have. So the community organization will be able to help do research that really targets those meaningful questions that I mentioned earlier. And then also, a lot of times community organizations don't have the research training or the expertise to design research. So partnering with a research partner will improve the effectiveness of their program and make it legitimate, often from a obtaining funding perspective, and then also from a conversation of how to implement something similar to their community organization in other domains. So this slide is really complicated and really wordy, and I'll break it down bit by bit. But I wanted to start with this because I wanted to impress upon everyone here that community engaged research is complicated, and it is really hard and has lots of challenges that I'm sure everyone here will talk about in the next hour. So I like to think about community engaged research in the way that I got introduced to it, and the way that I think an academic researcher often is introduced to it. So, for example, myself, these days I primarily identify as a researcher within the world of pre-hospital medicine, or EMS. And I'll use an example of a grant that I was working on a couple of months ago to talk about how community engaged research can kind of be applied within the EMS setting. So say, for example, for firemen, I'm interested from an academic standpoint about all the high rates of occupational injuries for firemen. In this case specifically, I had a couple of paramedic firemen who got sick or had to take a leave of absence. And I was really interested to see if this was a phenomena that I was just noticing in kind of amongst the people that I was being introduced to, or if there was something that we could do in a system standpoint to correct it. So just so everyone is aware, as an EMS doc, I do medical control primarily for these paramedic firefighters, but I'm not actually involved in the organizational components of the fire departments. So investigating why is often a politically difficult landscape. So some other context here is, as EMS physicians, especially for me, like, I don't have any firefighter experience. I'm new to the region, and there's a lot of politics when it comes to fire departments because they have funding from local resources. There's often a lot of politicians in the local governments who are really interested in what the fire departments are doing. From the fire department side, they're often a small department that doesn't have a lot of resources, and any loss of firefighters is really bad because they have 24-hour shifts, and then they have to fill those spots to ensure the safety of the community that they protect. And then thinking a little bit about the partnership process. So this is kind of in the very start, before I really started planning any sort of intervention or any sort of actual research, I met with the fire chief, I met with the paramedics, and I just started talking to them, right? Because if this was not something that they really found as something that's interesting or meaningful from their perspective, I guess the big question there is why pursue it? Because they're the ones who would live with the impact of anything that I would do. For me, the fire chief was really interested, mostly because, as I said earlier, they had so much attrition that they had to call in firemen to work when they were supposed to have a day off. And they knew that this would have a big impact long-term if it continued. So basically, we set up a partnership structure where we started meeting regularly. We started working with other organizations, people who funded the fire department, community members, et cetera. And really the fire department and kind of us in terms of meeting is how we set the aims in terms of our intervention and research. And this is kind of where we are right now. And I'll pass it on to the rest of the group really to talk about more in-depth conversations, but just kind of this back and forth meeting process of really figuring out what is the important aims of our project from at least an EMS perspective. And we hope to really get to some outcomes. For me, the main interest is identifying factors that lead to occupational injury, and then hopefully designing a program to basically mitigate those factors. But there's a ton of different interests right now related to this. Anyway, now I'll pass it on to John to talk about things a little bit more in depth.
Thank you. I'm going to both zoom out and really zoom in. I think one thing we often hear from younger researchers when they're starting to look at community engaged frameworks is we don't know where to start. And I think larger context can help people understand what's at stake and how to do this work. And then I want to provide a set of principles that I use to bridge some of the frameworks that David was talking about to my actual practice. And then I think Liz will provide some more specific illustrations. I think about community engaged research as being integral to addressing the credibility crisis that we currently face with regards to the sciences. And this credibility crisis is talked about in a lot of different language. Sometimes we talk about the death of expertise. Sometimes we talk about post-truth. The RAND Corporation has increasingly used the term truth decay. But what they add up to is a point in history where trust in the authority of science, and especially biomedicine, is lower than probably any time it's been in the last 200 years. And there are three components of this that I think we need to keep in mind when starting to think about community engaged and participatory research. First is this centuries-long alliance between the biomedical sciences and white supremacy and patriarchy. We often point to one or two examples like Tuskegee, but what we're really talking about is the domination of scientific institutions and scientific practices by racism and sexism from the late 1800s to the period of the Second World War, where coming out of the Second World War, there was a partial challenge of this dominance. The second element that contributes to this crisis of scientific credibility, we talk about broadly as the replication crisis, but we know is really a set of interrelated crises. Larger scale scientific fraud than we were previously aware of, reporting methods that have led to frequent failures of reproduction of experiments, misuse and misunderstanding of statistical methods, on a large scale, overpublication that's driven by career considerations and publishing industries, all of which have added up together to large scale failures of replication, not only in disciplines like psychology, but also in areas like cancer biology. And then third, we've seen a global use of anti-scientific sentiment by right-wing authoritarianism in order to attack and undermine the credibility of scientific institutions. And in this sense, Trump and COVID and around climate change is exemplary, but similar dynamics have played out with Bolsonaro and Brazil, Modi, and India. This is really a global phenomena. US medical journals, I feel like, are starting to tackle the first element of this credibility crisis and are fairly behind in tackling the second and third, which is more prominently covered in European scientific press. So I start here by in order to introduce a context of what it means when we go to the community. Because in an ideal world, these three forms of mistrust that have developed would be separate. But in the landscape of the internet and 21st century media, they blended together to create a kind of amorphous and diffuse anti-science ideology, which has led to everything from people protesting vaccines outside of hospitals to like the truckers' revolt in Canada against public health measures during COVID-19. In an abstract, we know many of these things, right? We read about them in the journals and in press, but I feel like few of us who are day-to-day working researchers have really started to take into account this larger context in how we do science every day, how we design our projects, how we engage with the community, how we actually think about and structure our practice of research. I think one way to think about community engaged and participatory research is it's a kind of on-the-ground science education, right? It's a means by which to engage diverse communities and teach about basic principles and practices of what it means to do science that can counter these forms of mistrust. Another way to think about it is a form of reparative work. It's trust-building work. We are doing science on a landscape of broken promises, some of which were broken recently and some of which have been broken for centuries. And in order to do science differently, we have to rebuild trust with these communities through a kind of reparative process of engagement. And I think that's not only an ethical imperative, but it also is increasingly a scientific imperative. There are basic questions of construct validity, external validity that I think community engaged research gives us the unique tools to address and work with. And I think, especially in climate change context, people are increasingly stressing that community engagement in the process of research is absolutely critical for communities to accept interventions and techniques that are developed after the research is done. So how to put that into practice? I'm going to offer quickly 5 principles and then hand it over to Liz. Some of which are just elaborate what David has already said. One is build genuinely connective relationships, that build relationships with people that are meaningful, that are equitable, that are founded on clear expectations on both sides, but also where people trust you to show up beyond when you need something as a researcher. In Rhode Island, where I live and work, the story we hear most often is about an epidemiologist at the Brown School of Public Health that allows community organizations to use his driveway to build pride floats every year as they're building floats for their pride parade. Gets nothing out of it. It's not connected with any project. It's just a way of showing up. That sense that people mean more than you than simply objects of research, but that you have a real connection that goes beyond your career benefits is foundational to this work. The second is I think I try to be very concrete about what I mean about community. Community is a very amorphous word that slides around a great deal. But communities are actual sociological cultural entities in the real world with actual borders, dynamics, and structures. Often when we talk about a community in a very abstract sense, what it leads to is kind of very vague forms of engagement. The kind of example is like, I've asked 6 people who are trans to be on my community advisory board. And of course, do I get insights from that? Often, yes, and often very meaningful insights. But what does it actually represent? What does it actually connect with? What is it actually giving me insight into? I don't do the work to unpack that or to understand that. So as a rule of thumb, I tend to start by trying to geographically sketch out the borders of my community, even if that's imperfect. I ask, what are the community organizations working in that space? I ask, what are the influential people who are not based in community organizations? Often that's community elders or younger activists. And then I ask who's being excluded from my working map. Every community is constituted by inclusions and exclusions and struggles over who is included and excluded. And when I start to have a sense of those struggles and the sense of disagreements around the issues that I'm researching, I feel like I've begun to understand the contours of the community that I'm working with. My third principle that I want to offer is think in terms of the long term and try to work in terms of the long term as well. If community engaged research is part of rebuilding trust that has been violated for decades or centuries, it is long-term work and involves long-term commitments with communities. That doesn't mean every researcher can make that commitment. Not everyone can move to a neighborhood and work for 30 years and engage there for 30 years. Sometimes we're doing a 6-month project. We need relatively limited community feedback. It's very delimited, and it's okay to show up and be honest about that. But there is somebody who has been in that neighborhood working with those community organizations for decades, and you should know who they are, and you should make sure that you're trying to collaborate with them, or at least not undercutting them. There's a real danger at this moment as we start to see more NIH and CDC encouragement for people to do community engaged research, for there being a flooding effect and large numbers of unprepared researchers who don't know the histories of their communities enter into communities with the best of intentions, but in fact end up doing harm. I think what this will mean is that we're going to move towards, in general, thinking from project-based engagement to larger structures of institution-based engagement. But as we're making that transition, if you're entering a new space, figure out who has been working there and figuring out how your work can support them. Listen to non-academic voices. Many of the community engaged in participatory research emerged out of Latin America and Tanzania in the 70s. It didn't emerge initially out of North American research methodologies. The pioneering work has been done by sex workers, people who use drugs, and especially indigenous communities. There are newer frameworks that have emerged, like indigenous statistics and indigenous data sovereignty, which are pushing the cutting edge of quantitative research as well as qualitative research. If you're only reading academic literature and listening to academic voices about community engaged and participatory research, you're missing a huge archive of expertise that's out there to engage with. My suggestion, if you're coming to this conversation rather new, is start with looking at what's being done in Canada around Indigenous communities, where there's been a far deeper truth and reconciliation process than in many parts in the world, certainly than in the United States, where there is none, and where Native First Nations, sovereign nations have developed very powerful frameworks around researchers working in Indigenous spaces and Indigenous communities. And my final suggestion is just an echo of David's. Think about the concrete benefits of your research. Too often, people who do biomedical research assume that the benefits are self-evident or don't need to be justified beyond themselves. And the reality is many communities see the things we research as being completely disconnected from their day-to-day needs. And that generates the strong impression that the research serves researchers professionally, but is really not driven by community needs. We're also not very good at explaining the benefits of our research, often explaining why trials can take years, explaining why we need multiple trials, for example, to approve a new drug. And so as we're explaining the benefits of our research, we both need to do a better job giving community members the larger picture, but also we have to understand that that larger picture is often not convincing for people who are struggling to survive day to day. And we need then to build in more concrete, more immediate benefits to our research that answer community needs as part of our study designs.
Thank you so much, John and David. John and I work together on research, and I just want to invite him to interject anywhere in the course of my presentation. So a lot of what I'm going to say is both reinforces what David and John have talked about. So I'm sorry for any repetition, but it's really going to focus on, how we build authentic partnerships and some of the core elements of that. And a lot of these things are things, I mean, we know how to build relationships with people. I think that there are some, things I have learned over time and learned from other people with more experience working at community engaged research over time that I hope is helpful to folks. But first couple concepts, which David covered very well, but community-based participatory research, community engaged research, community empowered research, these are slightly different things in a similar group of work, but these are an approach in which researchers and community stakeholders form equitable partnerships to tackle issues related to community health improvement and knowledge production. When we think about the flow of information and the power relationship between the research investigator and the community, traditional research, typically there's information flowing from the community to the investigator. Community engaged research, there's still can be a slight imbalance in both information sharing and power, with the community providing more of that to the investigator, but with some feedback to the community. And then community empowered research or community participatory research, depending on how you want to call it, really focuses on this equitable sharing, as David detailed and as John discussed. There are some really, focused or key concepts and steps that are really important to go through when developing your project. Some of these were already mentioned by both David and John, but community is the unity as a unit of identity. You have a circumscribed group of people you're working with. You understand the components of that group of people, and both in terms of who is a part of it, who is working with them, and what the stakeholders are. Community participatory research builds on community strengths, focuses on collaborative, equitable partnerships. Co-learning and capacity building is a key part. It's not just the researcher who is learning, it is also the community members, and the research work itself builds capacity in the community or in the community-based organizations that you're working with. And it also kind of in turn builds research study group capacity. It balances research and action. It is locally relevant and accountable. I would also add accountable to that. Does develop systems which can aid in the capacity building and sustainability of long-term work. It considers equitable dissemination, which I'll talk a little bit about today. It is sustainable and it comes from a place of cultural humility, and researchers should utilize cultural humility when approaching with and working with communities in community engaged research. So, John and I had several conversations leading up to this talk just to kind of think about, what are some of the components of the authentic relationships we have had and we have seen modeled that we think are really essential. So some of those components I'm going to talk about today are listening, trust building in terms of roles and relationships, resource sharing, communication, your research deliverables, and some component of letting go, which I'll talk a little bit more in depth. So listening. So listening is not just the absence of not talking. I think that while researchers, especially in the context of meetings with community members, can often take up a lot of space, and it is important that they take a step back and listen, it really is an active process, one that requires reflection and reflexivity on part of the researcher, acknowledging and the components of active listening. This is just like with a friend or a partner, right? So acknowledging the information shared, checking with the community group or the stakeholder, the person you're meeting with and trying to collaborate with, that you understand what they're trying to say. Meaningfully incorporating their suggestions and feedback into your research plan. It doesn't mean you take all of the feedback. A key component here, kind of building off of what John said, around educating your community partners around whether it's the scientific process or approaches or tensions or limitations that you face that they may not be aware of. But part of that can be acknowledging, I think that it is a really good idea. Unfortunately, I have limited funding. I have these requirements by the IRB. Here's what an IRB is. Here's what the process is. So they can kind of understand that some of the limitations or space that you're operating within and doing work with them, and the things you're trying to balance as you're trying to co-develop project designs together is really important. And that is also an example of kind of a mutual relationship. They sometimes don't know, they don't have insights into all of the things we're balancing or contending with or trying to incorporate into our research plans and designs, or why we might take a certain approach in terms of generation of both generalizable knowledge or relevant study designs and things like that. A key part of trust building, in addition to listening and information sharing, are the roles and relationships you develop with people. In addition to being a scientist, you're not just a scientist as emergency clinician researchers, you're also a clinician. You may be the only physician or clinician researcher that the community group you're working with knows. As a result, the resource you have to folks isn't just as a resource. Isn't just as a researcher, excuse me. It also, you may be able to provide some clinical support. I'm not saying you're providing clinical care to this group. That is a different thing, but you can help them navigate health systems. So maybe they have a lot of clients that are running to a specific health problem. You may be able to provide some advice. You may be able to provide some information and insights into how that institution works. So an example is that the community group that I work with, they have my phone number. They have clients when they may need to utilize the emergency department. They know that they can text me and I can provide them a little bit of advocacy, a little bit of support when they're encountering the healthcare system, which is very intimidating and often treats that group of people very poorly. So I can provide advice or guidance around, you should go to this hospital versus that hospital because they have more of what you need. They have services that may provide, or I may be able to provide some advocacy for them if they're in the waiting room. May be able to provide some supports for them in terms of advice or guidance or reassurance about needing to seek care. That can be very, very helpful, particularly in a very alienating or when they're in a very disempowered position when trying to seek care in a formal medical setting. Advocacy is not just individual, which I think is very helpful, but and really important and meaningful in terms of trust building. But your role as a physician and as a researcher is also a very important advocacy role in terms of policy. When I was in Rhode Island before moving to LA, I had the ability to have a little bit of a dual role at our Department of Health and was able to take part in some advocacy around state-related policy measures, often in coordination with and in support of our community-based organizations. This took the form of testimony at our state house, and you don't have to have a role at the Department of Health to provide expert testimony on key issues affecting the health of not only public health, but also of our community partners that we're working with. You can just go and do that type of testimony as a researcher, and offering yourself with community organizations if there is a key policy issue coming up that touches on or affects their community partners. You can always offer yourself as being able to give expert testimony as a researcher, as a clinician, as an emergency physician. We see this in multiple fronts. It could be around gun violence, it could be around drug policy, could be around housing issues. These are all issues that affect our community partners that some of us work with or that I work with. You have a really crucial role to play, especially for junior researchers. I wouldn't underestimate that you do have knowledge, you do have expertise, and you do have privilege and being listened to in a different way than your community partners may or may not be listened to. And that is incredibly important. To be able to show up for organizations who may be advocating for policies that directly affect the lives of the people they're trying to serve. The other ways you can show up for for organizations and partners is through resource sharing, and that might be through time. So maybe it is volunteering time with an organization, volunteering that doesn't necessarily have to be medical. Maybe the community-based organization you're working with is having a fundraiser. Maybe they're having an outreach event. Maybe they just need help preparing wintertime, like patient supplies kits. That type of time really goes a long way and shows that you really show up for them. It's not just a one-way street of like us getting data and interviews with their clients, but you're present and you're investing your time. Investing money is another really important thing. I'm not saying that you need to give all of your money away. That's not what I'm trying to suggest. But when we're working with a community organization and we are asking for their time to participate in their research, we need to compensate them as you would any research partner or anyone you work with or contract with. Their time is valuable. They could be serving clients, they could be doing anything else with that time, and they need to be compensated justly for that time. And then support. So a little bit what I talked a little bit about advocacy, but being able to provide support that could be and service that could be serving on the board of an organization, that could be being available to them to provide advice or guidance or information. That is really crucial, I think, both in terms of supporting the community organizations we hope to partner with, but in building trust and demonstrating and showing that it's not an extractive relationship. It is more of a mutualistic actual partnership in the research work and then outside of the research. Communication is crucial for trust building as well. A few key things to keep in mind. Communication should be prompt. You should circle back with folks in the community organization, not leave them hanging for long periods of time. And even if you don't know something or you don't have an update, providing information and let them know that you haven't just completely disappeared, and you are available to them if they do have questions. Communication should be respectful. I think that there are community norms and expectations you may not be aware of. So you might think that you are communicating with folks in a respectful, prompt way. And it's important to understand, what are the expectations and follow through and meet those expectations of that community. John's example or suggestion around, understanding who is doing longitudinal long-term work in a community and meeting with those people, I think is really important, not only for collaboration and learning, but you may be able to get instruction around how and to whom you would need to engage and communicate with to do effective work and trust building with your community-based partners. It's very important to have a clear purpose for your requests. Sometimes, I think inadvertently, when we engage community members or community organizations, we want to be very open, which I think is very good because you don't want to be too closed. But sometimes having too open of a request can be confusing, can be inefficient for the organization and actually create more work for them. So having a clear ask and a clear offer, what you're offering the community, doesn't mean you have to have a definitive actual thing. You might say a couple of different options, but at least having some type of purpose to reaching out and not putting too much work on the organization or the partner is very important. Similarly, I would also advocate that you try to minimize short deadlines. So, when we're writing grants, when we're writing papers, we are often under a lot of time pressure. And working with community organizations, you need to be clear, what your asks are going to be for them far ahead in your own deadline. So you're not asking them to turn something around in a day. They're not going to be able to do that. And it's going to really damage the relationship between you and that organization. Some organizations and some partners, they have more flexibility around that, or they understand that, or you've had a relationship with them for a long period of time. Those are a little bit different, but definitely upfront, short turnaround deadlines that are hasty and require a lot from them and within a small amount of time are going to erode any trust or any effective research you can do with that group. I already talked a little bit about understanding community communication norms and expectations. That's really key. That is something you might learn over time. And, certainly I think we are not perfect. None of us are perfect, but being open to that feedback or trying to test and understand, or even really asking directly what would work for them, what would be the best way to communicate or things going forward, is the way to try to get on top of and preempt that a little bit. And we already talked a little bit about this, but really trying to not make more work for the organization that you are hoping to partner with. They will have some more work because they're going to partner on the organization, but you want to make it as easy as possible. So for an example, John and I work on a research study right now, and we have an advisor looking at community health worker programs, people who are long-term recovery for patients with substance use disorders. We have an advisory board for that study of people who are community health worker peers and have worked as community health worker peers. And, we bring them very discrete things to talk about and also hold space for some more open-ended conversation. So, for example, at our last meeting, I guess that was last week, I'm losing track of time, we wanted to review a survey instrument. So we did have a very focused discussion about the survey instrument, but we also had, have had broader conversations at prior meetings about, how lived experience is operationalized in these encounters with patients. Is this something we can measure? Is it a mode of effectiveness? And those kind of broader conversations, but that was the result of a very specific ask. So they were able to show up and come to that meeting, provide really important, crucial insights that are important for the science and our research study. But they didn't have necessarily to do a bunch of legwork to be able to provide that type of input to the process. Aligning goals, which David touched on this quite a bit in his process, which I really liked. This is an example from work I had done. So my work in Rhode Island was a little bit unique because I had a researcher role and a clinical role at Brown, but I also had a role at the Department of Health. And then I was also doing work with community-based organizations. So the Department of Health, which is right listed here, they gathered a lot of data to do overdose surveillance. I had done some work with them as their assistant medical director, and we wanted to understand where overdose hotspots were and then potential to inform community-based interventions. So for me, I had this kind of dual role as researcher, both, my community-based relationship was with the Department of Health, but it was also with the people living and working in the community-based harm reduction organizations providing services in this place. So Department of Health collects these data. We did do analyses, we did community-based discussions around factors, resources in those neighborhoods and factors affecting increased overdose rates. And at the end of it, we did write a paper, a more traditional type of product, but we also provided data to the community-based organizations, which they use to inform what are the types of interventions we are going to do with our organization to try to reduce overdose death. And then they made their own, funded from the Department of Health through this kind of same project, community-based interventions and services and programs to try to leverage those data to reduce overdose deaths. And those types of that type of mutualistic process where, we're doing research, where we're defining characteristics of overdose hotspots to try to develop place-based interventions led by and implemented by the community-based organization, that does really help them do their work and further their work along as we're trying to understand, why overdose happens in some places and how we may affect outcomes of overdose. I'm going to talk very briefly about a different project. This is not my project. This is a project of some researchers at Brown and another emergency physician, Dr. Rachel Whiteman. It's called Test RI. And Dr. Alex Collins, she is at the Brown School of Public Health. They did a drug checking study. They got funding to do a drug checking study. And I think one of the most amazing things about this project is they really focused on delivering the results from their research in rapid, really short time to results and delivering that back to the community to try to reduce and prevent overdose. So not only did they check drug samples obtained from people who use drugs in Rhode Island, but then they would tell people what they found as a public health education update and disseminated it. This is just an example of their Twitter feed. They disseminated it in different ways. They used Twitter, they used Instagram, they had a website, they had materials they handed out on the street, they gave it to street outreach workers. And they're writing manuscripts, they're writing, scientific papers, but these other types of dissemination products, which directly affect the lives of the people who are part of the organizations that we partner with, are really critical and really key. There's such a long lag between the information we generate and implementation and then dissemination of that knowledge. And this makes it more almost real-time information available that's actionable to try to impact population health is really incredible and really inspiring. I highly suggest everyone check out Test RI. And then the last thing, I know we're running out of time. And this is, I think, very hard for us, is letting go. Not everything works out as planned. And there's some element of community engaged research that you just have to learn when to let go. So an example of this, my first research grant was as a resident, and I had done interviews with trans and gender variant folks about their experiences in the emergency department. We did a series of amazing focus groups. I worked with some amazing community partners. The community partners I worked with were involved in all parts of the planning process. People gave me great feedback about the interviews and their participation in the interviews. And I had this idea along with my community partners and my team, which was composed of many folks who are trans or gender diverse. And we were going to do a report back of what were the results of our interviews, what did we find, and what are the next steps we're going to do in our health system. So we had this whole presentation made. I got pizza. Nobody came. No one came to report back. And I think I initially, as a young researcher, I was like, well, how did I mess up? Like, what did I do wrong? Did I not do outreach enough? Like, maybe I didn't maintain my relationships well over time. There was this point of reflection, but also likely it had nothing to do with me. I have no idea, or maybe it did have to do with me, but there's also other things going on in people's lives. Maybe they lost a community member and people are dealing with that. Maybe they have to pick up their kids. Maybe the time of day I scheduled the report back may not have worked for people. There's endless numbers of reasons why that might not have been the right dissemination modality. I needed to pivot to figure out a different way to disseminate those findings. And because I wanted people to be able to see what we're doing with the information we collected with them, and what changes we were going to make in the health system as a result of that research. And it sometimes doesn't work out. It was a big learning experience for me, but I think understanding that is really important component of being a genuine partner and being a genuine researcher and being flexible. You may have had an amazing plan at the get-go of how you were going to engage people or how you're going to do this longitudinal research, but being honest with people, not tokenistic with the people you're partnering with is really important, especially for those long-term relationships. And I think admitting to partners when something is wrong or didn't go how you want. So that hotspot paper, for example, had lots of delays for various reasons. So being able to communicate with people, that it's delayed for these reasons, maybe they can help with the troubleshooting of how to fix it going forward. Again, that kind of closed loop communication, those longitudinal relationships can really minimize that type of exploitative, extractive researcher community dynamic. And then being willing to learn. Trying to figure out, what is the way to do this in the future that is accountable, that advances science, that improves population and public health, and also, preserves the integrity and quality of the relationship with the community organization that you're working with. This is just some repeat summary of key components of building authentic relationships. And I'm very looking forward to additional questions and discussion with everyone. If anyone has any questions, they can definitely email me.
Awesome. Thank you all very much. It's a fascinating conversation. I'm still young in medical terms. I'm still in medical school, but I worked in these community organizations and in community health for a number of years before med school. And there is just at times such a painful difference, a barrier between this ivory tower of medicine and where this medicine comes to life on the street and for the day-to-day lives of so many folks. It is exciting to see that transition being made. John, you mentioned this concept of more CDC and NIH funding having some element of community engagement built within it, the expectation that our research, that our work have community voice as a part of it, and hopefully working towards that standard that David talked about in the beginning of community members really being partners, equal partners in this process. And we've certainly got a long way to go in a lot of settings, but certainly progress being made. I did want to ask a couple questions based on some of the things that we heard a number of times here. One was there seemed to be this almost balance between formal and informal consulting. We talked about things like maybe a community advisory board that's held by the hospital or an advisory board for a specific project. And that may be a setting where we say, we want your opinion on this, where as researchers, we may set the direction or boundaries of that conversation, versus the informal element of where we may, leave it open. What is your perspective on this, or build relationships in the community, perhaps even without a specific project in mind. I'd be curious from some of you who've done some of this work, how do you find that balance? John, you want to start us off there? It's maybe up your alley.
My own experience has been that the formal components actually work best when they respect long-term relationship building, right? So when you have to have you can convene conversations and organize them effectively when you understand the community, the politics and the dynamics in the community that they're drawing from and are informing the conversation. Last week in Rhode Island, we held an unconference of community organizations and researchers where community members and organizations proposed topics to be addressed in community research relations in advance. Then the conference itself voted on the topics. We split into non-hierarchical groups for discussion, and then came back together to vote 3 priority issues in the state of Rhode Island to address in community researcher relations. But to do something like that was the outcome of 5 years of work developing principles of community-empowered research with 7 organizations and probably like 50 researchers. There have been dozens of cabs, panels, smaller discussions with the people involved over the years. And we still probably had 50 individual meetings with community organizations or members before the unconference itself to talk through what people needed, what they wanted, what the dynamics might be, what their anxieties were, to translate that back to research collaborators to adapt the approach of the unconference. So where it sounds like putting together a small community advisory board or a CAB is the lower lift. Often, if it's not informed by some type of deep knowledge of the conversation you're tapping into, you're getting a very imperfect reflection. Like a convenient sample of community voices is still a convenient sample. And in fact, given that we often don't explicitly talk about how we incorporate community feedback in our methodology sections, there's actually this way that, done poorly, these type of community feedback sessions can just reinforce our own confirmation bias as we recruit community members that reflect our views. And then our views are fed back to us in cabs, and then they kind of infiltrate our papers without a sort of rigorous accounting process. So you're getting a bit of like cynicism that's developing on my part. Maybe cynicism is too strong a word. Frustration that's developing on my part, that kind of like shortcuts in community engagement end up recreating, like putting together a community that's more an object of our imagination than a genuine reflection of this kind of living, breathing, dynamic entity that exists in the world.
I've got a note here from earlier in the talk of, the concept itself is relatively simple, right, of engaging community, but the reality of how to do it and the balancing act and all of the pieces that need to come together to build those relationships can be such a challenge and such a long-term goal. I love that idea of the unconference and the recognition that really is the materialization of years of work going into that. I know we're just about out of time here, but we would be remiss if we didn't ask, obviously a lot of these things that we talk about are long-term things. We talked about how oftentimes our community partners may expect some sort of results shorter term, and in the lens of medical research, that may or may not be viable with the kinds of research projects that we take on. And the reality that building those sorts of long-term relationships and building those sorts of long-term research trials requires quite a bit of infrastructure and funding. John, you mentioned earlier this idea of transitioning from project-based engagement to institution-based engagement. And very similarly, that requires an institution with quite a bit of resources. Is it reasonable to be concerned that that kind of transition and the kind of resources necessary to do that means that this kind of truly community engaged research isn't practical in all settings? Dr. Samuels, I'd be curious on your perspective on this as someone who has moved between a couple institutions.
Yeah, and so this is a little bit, maybe repeating a little bit, but I do think, some research takes a long time. Some research has nearer term outcomes, right? So I think touching on what David said around, what are the concerns or questions? I think the example that David gave is perfect, because there's near term concerns or questions that people have that he is going to investigate to hope to build a long-term intervention to improve outcomes. That's a long-term project. There's a nearer term goal within a longer term project, and being able to articulate that to folks about like what's doable on what time scale and why and how, and what some of the nearer term positives might be, I think is very helpful. And I think that's important for us as researchers also, and when we think about our own timelines, what are the things we can wrap our hands around right now, or what are the elements that need to be done up front to be able to do the longer term work, and just being clear about that and what those expectations are. And I think goes a long way. I think I have changed institutions. I mean, I think and I've worked to maintain my relationships in a place where I still have ongoing work. But people, I think that it is hard, but you also, like anyone who moves away, right? You tell people you're moving away, you prepare them for that, what the new relationship is going to look like. I have ongoing work that I have planned into my ongoing work that I go back there and see the people I work with, do regular work with them. I have partners who are local, like John, who was a co-investigator on my grant. So it's not just me. That's the other thing too, is you build a team of people that have a relationship with the people you're doing research with. Certainly you do have individual relationships, but when you think about, like when I think about my research team now, when I'm building them, I really think very seriously, are these people, am I bringing people on my team who I trust with the relationships with this community organization? And if the answer is no, then I don't bring those people onto my research team, because that relationship and that collaboration with that team, and they may have a different role in the team, but particularly project directors, outreach folks who are interfacing directly with my community partners, those are very precious relationships that need to be maintained, and that kind of trust and understanding needs to be shared amongst everyone on the team. And you can train people up, you can develop them and support them and strengthen those relationships, because it ends up needing to be beyond you just as the PI.
Absolutely. I am sad to say that we're out of time. This is certainly a topic that we could talk about for years and years to come, and frankly, I hope it is a topic we talk about for years and years to come. Thank you again to all three of our speakers for joining us today. It's an important conversation, something we don't talk enough about within the concept of emergency medicine research. Looking forward to continuing to make progress.
Thank you so much for having us.
Thank you.